Mildred called her daughter at 6:30 on a Tuesday morning. She said, "My legs feel like they're not mine." Her daughter said, "Mom, you've said that 3 times this week." Mildred had been on metformin for 11 years. Her blood sugar was managed. Her A1C sat between 6.8 and 7.2. Her endocrinologist was satisfied. And for 3 of those 11 years, Mildred had been calling her daughter at odd hours to describe a sensation she could not explain. A heaviness in the legs, a numbness that spread from her feet upward, a fatigue that wasn't tiredness, just a strange disconnection from her own body. Her neurologist called it diabetic peripheral neuropathy. Progression was expected. Management was the goal. Nobody tested her B12. Not once. In 11 years of quarterly labs. I want to show you today what metformin does to a specific vitamin your nerve fibers cannot function without. Why the deficiency this medication creates is almost never tested for in standard diabetes management. What happens to both your blood sugar and your peripheral nerves when that vitamin is corrected? And why, in Mildred's case, and in an estimated 20 to 30% of long-term metformin users, the neuropathy being attributed entirely to diabetes may in fact have a second driver that is completely correctable. What I'm about to walk you through has been known in the medical literature for over 2 decades. It has been flagged by the American Diabetes Association in their guidelines, and in a 15-minute quarterly appointment focused on the A1C number and medication adjustments, it is almost never mentioned. The vitamin is B12. The form that matters is Methylcobalamin, and the mechanism by which metformin depletes it is specific and documented. Metformin is transported into intestinal cells by a protein called OCTN1. Research has shown that metformin competes with the vitamin B12 intrinsic factor complex for calcium-dependent receptors in the terminal ileum, the section of the small intestine where B12 is absorbed. When metformin occupies these transporters, the B12 intrinsic factor complex cannot bind. B12 passes through unabsorbed. This is not a rare side effect. A cross-sectional study published in PubMed found that approximately 28% of metformin-treated type 2 diabetic patients had B12 deficiency. Other studies report prevalence ranging from 17 to 40%, depending on dose and duration. The longer the metformin use, the higher the dose, the greater the depletion. B12 deficiency in adults over 60, independent of metformin, affects approximately 20% of the general population. In seniors on long-term metformin, these 2 risks stack. My name is Dr. Leonard Javier, and in Mildred's case, they had been stacking silently for 11 years. Her B12 level, when it was finally tested, 164 picograms per milliliter. The reference range most labs use starts at 200. Many functional medicine practitioners consider 300 to 400 the level required for normal neurological function. Mildred was at 164. 11 years of quarterly labs, never tested. Now I want to give you the 7 things B12 deficiency is quietly destroying. In reverse order, least severe to most. Because understanding the full cascade of what this deficiency does makes it impossible to dismiss as a minor nutritional footnote. Number 7. Energy metabolism. B12 is a cofactor for methylmalonyl-CoA mutase, an enzyme in every cell's energy production pathway. When B12 is insufficient, methylmalonyl-CoA accumulates. Cells produce energy less efficiently. The result is the specific fatigue most B12 deficient patients describe, not the tiredness of exertion, but the heaviness of simply existing. Mildred's description: like walking through water. This is why the fatigue of B12 deficiency is so often misattributed to aging, to diabetes management burden, to depression. It does not feel like exertion fatigue. It feels like weight. And it lifts, sometimes within weeks of repletion, in ways that patients describe as coming back to themselves. Number 6. Cognitive sharpness. B12 is required for the synthesis of myelin in the central nervous system, as well as the peripheral nervous system. The brain's white matter, the insulated nerve tracts that carry signals between regions, degrades progressively in severe B12 deficiency. The clinical presentation is subtle at first: word-finding difficulty, slower processing, mild memory lapses. The clinical term for the severe form is subacute combined degeneration, but the early cognitive effects appear long before any imaging changes. For seniors already managing the cognitive load of diabetes, tracking blood sugar, managing medications, monitoring symptoms, the added cognitive friction from marginal B12 deficiency is both real and invisible. It presents as aging. Nobody tests the vitamin. Number 5. Red blood cell formation. B12 is required for proper DNA synthesis in red blood cell precursors. In deficiency, these cells cannot divide correctly. They enlarge without dividing, producing macrocytic anemia. Fewer but larger red blood cells that carry oxygen less efficiently. The fatigue deepens. Breathlessness on mild exertion appears. A standard complete blood count will show elevated MCV, mean corpuscular volume, which any lab report includes. The connection to B12 is not always made. Number 4. Homocysteine accumulation. B12 is required for the conversion of homocysteine to methionine, a reaction catalyzed by methionine synthase. When B12 is deficient, homocysteine accumulates in the blood. Elevated homocysteine is an independent cardiovascular risk factor. It damages the endothelial lining of blood vessels, promotes inflammation, and accelerates atherosclerosis. In patients with diabetes whose endothelium is already under glycation stress, elevated homocysteine from B12 deficiency compounds the vascular damage from a second independent direction. This is why B12 supplementation in seniors with elevated homocysteine has documented cardiovascular protective effects, separate from its neurological role. I want to address something that keeps people from taking this seriously even after they get their B12 tested. The standard serum B12 reference range on most American lab reports: 200 to 900 picograms per milliliter. A result of 210 is flagged as within normal limits. 250, within normal limits. 300, within normal limits. The research on neurological function tells a different story. Multiple published studies have documented measurable neurological impairment in patients whose serum B12 is between 200 and 300. Technically within the lab's reference range, but in a zone where myelin synthesis is insufficient for normal nerve conduction. A review published in the journal Neurology found that neurological symptoms of B12 deficiency, including peripheral neuropathy, appeared in patients at levels between 200 and 300 picograms per milliliter that would be flagged as normal by most lab references. The researchers proposed that a functional threshold of 400 to 500 is more appropriate for neurologically symptomatic patients. This is why Mildred's level of 164 was neurologically catastrophic. But it is also why a level of 240 might produce symptoms while appearing normal on a lab report. When you receive your B12 result, do not evaluate it against the bottom of the reference range. Evaluate it against 300 as a minimum functional threshold for seniors, particularly those on Metformin. If your result is between 200 and 300, you are in the zone where neurological insufficiency is documented even when labs call you normal. Mildred's daughter, now a registered nurse, puts it simply: the lab says normal, the nerve says otherwise, trust the nerve. Quick note: what's happening to those blood vessels overnight, while B12 deficiency allows homocysteine to accumulate, is directly connected to the midnight insulin trap. Both the overnight blood sugar mechanism and the overnight homocysteine load on the endothelium are running simultaneously. Link in the description. Number 3. Blood sugar regulation. This is the connection most endocrinologists treating diabetic patients on metformin have never discussed out loud. B12 is involved in the methylation cycle, the process by which methyl groups are transferred between molecules for gene expression, neurotransmitter synthesis, and metabolic regulation. When methylation is impaired by B12 deficiency, the expression of genes regulating glucose metabolism is disrupted. Specifically, impaired methylation affects PPAR gamma expression, the nuclear receptor that regulates insulin sensitivity at the gene level. The same receptor that bitter melon activates that we covered in the insulin resistance vegetables script. Additionally, published research has shown that B12 supplementation in metformin-treated type 2 diabetic patients produces measurable improvement in glycemic parameters. A randomized controlled trial published in the Journal of Clinical Endocrinology and Metabolism documented that B12 supplementation alongside metformin improved fasting glucose and HbA1c compared to metformin alone. The mechanism. Correcting B12 deficiency restores the methylation efficiency that B12 depletion was suppressing, improving the cellular environment for insulin signaling. The medication causing the B12 deficiency is the same medication managing the blood sugar. And correcting the deficiency the medication creates improves the blood sugar the medication is managing. That loop has been in the published literature for years. Most patients who have been on metformin for 5, 10, 15 years have never been told it exists. Number 2. Peripheral nerve fiber integrity. B12 is a structural component of myelin, the insulating sheath around peripheral nerve fibers. In deficiency, myelin synthesis slows. The sheath thins. The nerve fiber beneath it becomes exposed to the inflammatory environment surrounding it. The nerve misfires. The symptom presentation is identical to diabetic peripheral neuropathy from oxidative stress: numbness, tingling, stalking distribution sensory loss beginning at the toes and moving upward. The clinical distinction matters because the mechanism is completely different. Diabetic neuropathy from oxidative stress requires antioxidant intervention, alpha-lipoic acid, which we covered in the Francis script on this channel. B12 deficiency neuropathy requires B12 repletion. They can coexist and compound each other. Mildred's neurologist attributed her symptoms to diabetic neuropathy. He was not wrong. He was incomplete. 11 years of metformin had been simultaneously depleting the vitamin her nerve fibers needed to maintain their myelin, while diabetes oxidative stress was independently attacking the same structures from a different direction. A key clinical distinction. B12 deficiency neuropathy tends to be more symmetric, more sensory than motor, and more responsive to supplementation than pure diabetic neuropathy. Nerve fibers damaged by B12 deficiency, particularly in the earlier stages, before irreversible axon loss, can partially restore function when B12 is corrected. The myelin synthesis restarts. The sheath begins rebuilding. Number 1. The accumulation. Everything I described in items 7 through 2 is running simultaneously in the same person. The fatigue, the cognitive friction, the anemia developing quietly, the homocysteine attacking blood vessel walls, the blood sugar not responding as well as it should, the nerve fibers thinning. All of it from the same deficiency that nobody tested. I want to expand on the blood sugar connection specifically, because most endocrinologists treating metformin patients have never connected the B12 they're depleting to the glycemic control they're managing. B12 is essential for the methylation cycle, the process by which methyl groups are added to DNA, proteins, and metabolic intermediates to regulate their activity. When B12 is deficient, methylation is impaired across the entire metabolic system. In the context of blood sugar, impaired methylation affects 3 specific processes. First, the expression of PPAR gamma, the nuclear receptor regulating adipose tissue insulin sensitivity and glucose uptake. Impaired methylation of the PPAR gamma promoter reduces its expression. insulin sensitivity worsens. Second, homocysteine accumulation, which we covered in Exhibit 4, directly activates inflammatory pathways that impair IRS1 signaling in muscle cells. The same pathway visceral fat drives through its cytokines. B12 deficiency is adding an independent inflammatory driver to the insulin resistance picture. Third, mitochondrial function. B12 is required for the conversion of methylmalonyl CoA to succinyl CoA in the citric acid cycle, the core energy production pathway inside every cell. In deficiency, methylmalonyl CoA accumulates and impairs mitochondrial function. Impaired mitochondria are less efficient at glucose oxidation. Less glucose is burned for energy. More remains in the bloodstream. A randomized controlled trial published in the Journal of Clinical Endocrinology and Metabolism specifically studied B12 supplementation in metformin-treated type 2 diabetic patients. The B12 supplemented group showed significantly improved glycemic parameters compared to the metformin alone group over the study period. The mechanism: restoring B12 corrected the methylation deficiency, impairing insulin signaling and mitochondrial glucose metabolism simultaneously. 2 actions. 1 vitamin. The medication causing the deficiency. The deficiency impairing the thing the medication is managing. This is the loop that nobody in a 15-minute appointment has time to explain, and that I am explaining now. The overnight connection. B12 deficiency affects the methylation cycle that regulates how your liver processes glucose between midnight and 5 in the morning. The midnight insulin trap covers the overnight liver glucose mechanism. The B12 methylation layer is part of the same overnight metabolic picture. Link in the description. The form of B12 that matters. And this is where most people who try to correct their own deficiency miss the benefit. Cyanocobalamin. The form in most standard supplements. Cheap to manufacture. Shelf-stable. Requires your body to convert it to methylcobalamin before it can be used by nerve tissue. The conversion requires adequate folate and specific enzymes, both of which may be compromised in seniors with metabolic dysfunction. Many people take cyanocobalamin, see their serum B12 level normalize, and still experience neurological symptoms because the conversion pathway is not completing. Methylcobalamin, the biologically active form, crosses the blood-brain barrier more efficiently, used directly by nerve tissue for myelin synthesis without conversion. For seniors with neurological symptoms, particularly those who have been on metformin long-term, methylcobalamin is the form the research supports. The dose. For B12 deficiency correction, particularly in the presence of neurological symptoms, standard oral supplementation uses 1,000 micrograms of methylcobalamin daily. This sounds like a large dose. B12 toxicity has not been documented at any oral dose. It is water-soluble and excess is excreted. Where to buy? Jarrow Formula's Methylcobalamin sublingual tablets at Walmart. 1,000 micrograms. Dissolve under the tongue. Approximately $12 for 100 tablets. Nature's Truth Methylcobalamin at Walmart. Solgar Methylcobalamin at Target. Sublingual delivery, under the tongue, bypasses the intestinal absorption pathway that metformin is blocking. This is not a minor detail. It is why sublingual B12 works even in people whose gut absorption is compromised. One additional option your doctor can prescribe: B12 injection. If your serum level is severely depleted, intramuscular B12 injection delivers the full dose directly into circulation, bypassing the gut entirely. If your level is below 150 picograms per milliliter, ask about injection. If your level is between 150 and 300, sublingual methylcobalamin is the appropriate correction route. Before the protocol, 3 combinations that determine whether this intervention succeeds or fails. Do not combine. 1. B12 methylcobalamin with antacids or proton pump inhibitors at the same time. Even sublingual B12 partially relies on some gastric acid for processing before entering the bloodstream. Proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, reduce gastric acid production and further impair B12 absorption beyond what metformin is already doing. This is a double stacking of the absorption problem. Take sublingual B12 at least 2 hours away from your PPI. Alternatively, ask your doctor whether the PPI is still required. Many seniors were started on PPIs for short-term indications and never taken off them. Do not combine two. High-dose folate supplementation without first correcting B12. Folate and B12 are metabolically linked. If B12 is deficient and you take high-dose folate, the folate can mask the hematological signs of B12 deficiency. The macrocytic anemia normalizes on lab work, while the neurological damage continues underneath. The clinical term is masking, and it is why the standard recommendation is to always test and correct B12 before adding high-dose folate. If you take a multivitamin containing folate, confirm your B12 level is within the functional range first. Do not combine. 3. Waiting for symptoms to worsen before testing. This is the most important combination to avoid. B12 deficiency neuropathy, if caught early, within the first 1 to 2 years of deficiency development, is at least partially reversible. If caught at year 5, 10, or 11, as in Mildred's case, the recovery is partial. Axon loss beyond a certain stage is not recovered through supplementation. The myelin rebuilds. The axon itself, once degenerated, does not. Ask your doctor to add serum B12 to your next lab panel. Today. Not at the next appointment you cannot get for 6 weeks. Call and request it added to your existing orders. If you have been on metformin for more than 5 years and have never had a B12 level drawn, that test is arguably the most important addition to your blood work this year. One more connection. The methylation cycle that B12 restores also regulates the gene expression governing how your liver processes glucose overnight. The midnight insulin trap covers the overnight glucose release mechanism from the liver side. B12 deficiency is one of the upstream factors disrupting that mechanism. The guide and this protocol address the same overnight picture from different angles. Link in the description. Here is Mildred's protocol, the one that started with a phone call at 6:30 on a Tuesday morning. Step 1. Get the test. Call your doctor's office this week. Ask for a serum B12 level on your next blood draw. If you are on metformin and have never been tested, reference the American Diabetes Association guideline that recommends periodic monitoring in long-term metformin users. You have clinical grounds for requesting this test. Step 2. If your level is below 300, supplement. Gero Formula's Methylcobalamin sublingual tablets, 1,000 micrograms. Place 1 tablet under the tongue daily. Allow it to dissolve completely. Do not chew or swallow immediately. The sublingual absorption route bypasses the gut receptor competition that metformin is creating. Retest at 3 months. The serum level should be measurably higher. If it is not, or if it remains below 300 despite supplementation, talk to your doctor about intramuscular injection. Step 3. Track the right things at the right time. Energy. Track weekly average, not daily. The fatigue of B12 deficiency lifts over weeks, not days. A 7-day average energy score compared week by week is more informative than daily tracking. Neurological symptoms. Track your sensation in your feet weekly. The same 1 to 10 scale used for neuropathy tracking. At 3 months, compare week 1 to week 12. Nerve fiber myelin rebuilding is slow, weeks to months. Do not abandon the protocol at week 4 because the numbness has not resolved. The recovery timeline for B12 deficiency neuropathy in long-term deficiency is 3 to 12 months of consistent supplementation. Blood sugar. Check your fasting glucose more frequently in the first month. If B12 correction improves methylation and consequently improves insulin receptor signaling, your fasting readings may begin trending downward. If they do, tell your doctor. Your metformin dose may need adjusting. For type 1 diabetes, B12 depletion from metformin is specific to metformin users, but B12 deficiency from dietary restriction, from atrophic gastritis common in seniors, and from proton pump inhibitor use affects type 1 patients equally. If you have been on a proton pump inhibitor for more than 2 years and have never had a B12 level drawn, this applies to you regardless of diabetes type. Drop how many years you've been on metformin in the comments below. Just the number. I read every one. Because the pattern I expect to see in those comments will say something important about how routine this deficiency actually is in the people watching this channel. Mildred's daughter asked her, at the 6-month mark, what she would tell someone just starting this protocol. Mildred thought about it. She described the moment her legs started feeling like hers again. Not dramatically, not overnight. A gradual return. Like circulation coming back to a foot that had fallen asleep. First warmth, then sensation, then something she described as recognition. She said, I would tell them to get the test first, and then not give up before the 6 months. And one more thing she wanted said. The burning in your feet and the numbness, they have more than one driver. The oxidative stress from diabetes damages the myelin from one direction. The B12 deficiency that metformin creates damages it from another. Both are documented. Both are addressable. And I made a video about the first driver, the oxidative stress pathway, and the compound that has been a prescription treatment for this in Germany since 1996, that most neurologists in America have never mentioned. If you have neuropathy symptoms, burning, numbness, the stalking sensation, that video and this one work together on the 2 separate mechanisms driving the same damage. That video is right here. Senior Health Blog. We'll see you in the next one.